Thank you very much. So Ujala Sickness has had a very long and turbulent journey, we may call it. We started with a small 10 by 8 clinic because we came from very resource crunch families. We did not have any money to offer healthcare, but we thought that there was a clear-cut pain point that was that people in small towns did not have access to good quality healthcare. So I remember our initial budget meetings would be like that: we need to buy a glucometer this month, which is 1200 rupees, but a nebulizer is more important, which is 1500 rupees. So how do we decide which one to buy? It's 300 rupees costlier. And I remember waking up at 3 a.m. and running to the hospital, which was say 10 kilometers away, to see a patient whose ECG had been done, and the resident could not understand what exactly the ECG was showing, and I had to go and see a normal ECG and say at 3 a.m. that don't worry, the patient is fine. And of course, everything has transformed greatly since then. WhatsApp came in, and then WhatsApp media came in which we could see the ECGs that were being taken. The patients could send their own ECGs to us, and of course, then telemedicine and a lot of artificial intelligence and machine learning has now started coming in. So we are employing a lot of that to do our CT scan diagnosis. We've installed ECG machines at most of the outreach clinics around our hospitals in the villages and small towns, which do automatic ECG interpretation in partnership with another organization. So actually, we sometimes call that doctor sitting in the village that there is a heart attack patient in your clinic who's getting the ECG done right now, and we can see that. And that doctor does not know really how to interpret that ECG. In addition to saving lives, it of course increases the revenue, as well as we can actually then pull the patient in very quickly to one of our cath labs to get treated. We do a lot of CT scan monitoring, as I said, through machine learning and through remote technologies, because we do not have enough radiologists to cover our hospitals 24 by 7. So in the night times, they come only for ultrasounds. Otherwise, if an ECG or X-ray or a CT scan has to be done, we can get them reported through machines as well as through radiologists sitting remotely. So doing a lot of work on technology. We are doing now completely paperless initiatives. So our Srinagar hospital is the first truly paperless hospital in our network. It's not paper light. So anything from prescription to a drug dispensing to even supply chain management, everything is done paperless in that hospital, and we hope that we'll replicate it across all our hospitals very quickly. See, the push for generic medicine is very good theoretically. In a wider sense, I think it's a very good proposal, but unfortunately, the government has missed the finer points in it completely, and they've been misguided, or they don't really know exactly what the scenario is, which I think they need to reconsider. So in India, the first problem in generics is that there are no bioequivalent studies which are necessary before a drug is granted license as a generic bioequivalent. So you don't know if that drug is delivering 100% or 80% or 70% of the efficacy that the patented drug is offering, and so it will be difficult for you to adjust the dosage of that drug because the bioequivalency is not really established. The second and the bigger point is that generics in India are not really low cost. That is a myth. So you have many branded generics which are not the patent drug. They are the same molecule as the patent drug but by a different name, and they may actually cost twice as much as the patented drug, right? So the chemist who is sourcing that drug will get it at 1/10 of the cost, but then the MRP on that drug will be twice as that of the patented drug. So the margins will be 20 times for the chemist or the pharmacist dispensing it. That actually puts power more into the chemist's hand than the doctor's hand. So a doctor may write a generic molecule, but then the patient may get a drug from the chemist which is twice as costly as the costliest or the highest quality patented drug. So if a generic has to be prescribed, it should be made sure that there is no brand on it and it is much less costlier than the patented drug, which the government right now is not really opting for, except for drugs under the DPCO, which is the drug price control orders. So drugs already under DPCO, whether they be generic or patented, will have a price cap on them already. So all necessary drugs, essential drugs are already under DPCO by the government. So this move to prescribe generic drugs may not really work to save money for the patient as the government intends. So it is a good natured and a good intended order, but it will for sure not achieve the purpose that it has been sent out for. So we've been taught about this, I think, ever since we entered medical school, and it is labeled as the ABC: pleasing and smiling. And if you are able to communicate well with the patient, if you are able to put across your points and you are able to hear the concerns of the patient, communication cannot be only one way, that just I am speaking and the patient is listening and then patient leaves and does not understand anything. So I should be able to hear the patient, understand what their concerns are, what they want to say, what they want to ask. If these three things are there in each and every doctor-patient interaction, then rest of the things sort out themselves automatically. The problem right now is the balance in the interaction between the patient and the doctor is completely one-sided. See, doctors have all the power in that interaction. If I say to you right now that you're having a heart attack, you need to lie down, you need to put in a stent immediately, otherwise the moment you walk out of this door, you'll be dead. In this interaction, you have no power, right? You cannot say, no, I want to have a second opinion. I'm saying you'll be dead within 5 minutes, right? So you say, okay, doctor sahab, you do whatever you want. If this happens, the patient feels quite powerless. And once an adverse event happens, then the patient feels that I had no power in this transaction, the doctor drove that transaction completely, and now it has gone wrong, so that is his complete responsibility. And then all these lawsuits and violence against doctors, all of that come in. So if we can ensure that patients have equal power in the transaction, they have equal say, then most of these problems will go away. So building a hospital is one of the most difficult businesses. You should keep that in mind. And I've seen many people falling into the excitement of seeing that, hospitals should be earning a lot of money. I went there and I paid ₹1,00,000 bill, so they should be earning a lot of money. It's not really that. The expenses in the hospitals are huge. The technology that we need to employ is huge. So if you are trying to build a hospital, first of all, try to think which is the community that you are trying to address. So if you are looking to address a community which is financially constrained, the hospital that you build should be very different from if you are trying to address a community that is highly financially empowered. These are two different businesses altogether. They may look the same, but they are two very different businesses. So first of all, try and see what are the communities that you are targeting. Second, what is the disease prevalence in those communities. So sometimes heart disease may be highly prevalent, but sometimes diabetes may be highly prevalent in that area. In some areas, infectious diseases may be more prevalent. In some areas, kidney diseases may be more prevalent. So you need to make sure that you structure the hospital according to the disease prevalence of the area. It won't look good if you have a 20-bedded dialysis center in a hospital and there is no kidney failures around that area and you are doing 1 or 2 dialysis every day, and so your infrastructure goes for a toss. Third, of course, you need to really make sure that you get the best medical talent on board. Ours is a hugely human resource intrinsic and intensive industry. You can have the best machines on the planet, but if you don't have a cardiologist to operate your cath lab, it will stay logged. Nobody will even know how to switch it on, let alone do a procedure. So getting the best doctors and retaining them, then getting the best nurses and retaining them, because I sincerely feel 60% of the quality that a hospital has is due to nurses. So if you do not have good nurses, the best cardiologist may come, do the angioplasty and leave. But if the nursing care is not proper, the patient will never be happy. So retaining that talent is the most important thing. And fourth, of course, we see many hospitals faltering because we put in the initial money, we build a very good quality hospital, we bring in the doctors, but then we fail to account for the working capital needs that we will have, because most of healthcare is now shifting to insurance-based care. So you do not get cash upfront. So you will treat a lot of patients. Their insurances will pay you after 3 months or 6 months, but you will need to pay your doctors, your vendors, your staff salaries all at the end of the month. And you will realize, oh, I don't have any money because the insurance still hasn't paid me, and then you will go into a vicious cycle which will keep going down because you are not able to pay salaries on time, you are not able to pay vendors on time. So you need to have very dedicated funds set aside to make sure that your working capital needs are there. You do not put everything in at once. So you keep some fund aside to make sure that for the next 3, 6, 8 months, you have enough capital to make sure that you keep pumping in more and more money. Because hospitals on an average will take about 2.5 years to become cash break even. So they may become profitable very quickly in 7, 8 months, but the cash cycle that they need, because every month you'll be treating more patients. So more and more expense you'll be doing, and that expense will come at 6 months later to your bank. So every month you will need more and more money till about 2.5 years. So people forget that they need it, and then after 6 months or 8 months, when the money runs out, it becomes very difficult for them to sustain. And then they start switching off lights, switching off air conditioners, paying lesser to their doctors, getting staff which is less competent, and the hospital starts on a downhill slide very quickly.